We then realized that it may not be a good idea and not possible to go to different places and do the programs every time. So we started with the e-learning, starting off with the free YouTube videos. And there are over 400 videos which are available freely in that perspective. And these videos basically are accessible to across the globe. And a lot of people have been accessing these videos over this time. And as we are looking at currently, there are a lot of people who are subscribing even to this program as well. So there are over 1.5 million views which have been given in these videos in terms of this e-learning program. We then realized that we needed to have a structured program rather than just having some videos. So we started off first with a fellowship program from 2017. And till date in the Regency Center of Diabetes Endocrinology and Research, we have had 11 fellows who have been involved. And I remember Dr. Kapoor, when we went for the first time, and he said that, yes, we should start the program. It was one of the few centers which started the program at that point of time. So in the last 7 years, continuously, we have got very good fellows and with good support from the hospital. In 2018, we started the online learning portal MedEClasses, and then a lot of books and application came up. So we have got pediatric endocrine learning tools. We have got fellowship programs in pediatric endocrinology, a 2-year course. And many of the people who are here actually are part of that course. They are coming 4 times in a 2-year period to gain experience, clinical, as well as learning in that perspective. We have developed the MedEClasses Endocrinology app, which I was talking about. It's the most downloaded pediatric endocrinology app with over 5,000 installs, a lot of publications coming onto it. We are working in terms of developing connected clinics, which will help out people develop personalized care in terms of specific disorders. So we have developed tools to guide evaluation for growth failure, which have been validated. There are tools for management of diabetic ketoacidosis, which have been shown to reduce the complications of DKA. We have developed a bone age application, which provides within 2 minutes a reliable and valid way to assess bone age, which has already been published. A lot of other interpreters are there, which are being published, include our obesity interpreter, our puberty interpreter, as well as thyroid interpreter. So these interpreters are going to make life very easy. You have to enter the values and you will get the right outcome. And they have been validated in a large number of patients in that perspective. We also developed a DSD interpreter. And the next step, which Vibha was talking about, was the bone age assisted interpretation of growth, in which all the pediatricians have to do is to enter some basic information with regards to the child in terms of their age, in terms of their birth weight and other parameters. And then you have to enter about their pubertal status. And then you can either have a manual entry of bone age, or you can have a data which you have to select the sites and get the right data in terms of bone age. Now, this bone age assisted interpretation of growth is a tool we have been using and validating for the last 1 year in our center. And this has been found to be perfect in terms of not only plotting the data, but also getting a lot of interpretation and whether our puberty and growth is going normal or not. So this is going to be probably a way in which we can really screen a large number of normal children, as well as patients who are coming to different pediatricians in terms of school, as well as clinic, to get the right guidance in terms of evaluation and management from that regards. So we've got different courses. We have on-site course. So we have had 7 on-site courses till now. And yesterday we had a big number of around 48 participants from across the world actually, and over 300 patients who had come from different parts of the country to specifically come and get exposed in this perspective. We have got multiple publications, and we have now coming up today with the 2nd edition of MedEClasses Basic Pediatric Endocrinology. So when we talk about calcium, we should know that circulating calcium is only 1% of the entire body calcium. 99% of calcium is in the bones, and most of it is locked there. So you are not able to get it out. Now, this calcium basically is then, once in the blood, is bound to albumin in 40% cases and phosphorus in 10%. But the free calcium is what is very, very important from our perspectives. So conditions wherein your phosphorus level goes up, your ionic calcium will become less. If your albumin becomes more, you will have hypocalcemia in that regards. Now, when would your albumin levels go up? So basically, if you have alkalosis, the ionic albumin, negative albumin will become more, the calcium will be bound more, and you will have hypocalcemia. And this is something you have to worry about. So if you are having hyperventilation, respiratory alkalosis, or somebody is giving soda bicarbonate, that causes tetany to develop, and this is important from that regard. So ionic calcium is what we are really looking out in terms of evaluation. So as I said, if you have alkalosis, you will have deficiency of ionic calcium, which will cause a problem of hypocalcemia. Now, calcium homeostasis basically has got three major organs and three major endocrine systems which are working. So we have got the bone, the kidneys, and the intestine. The most important acute regulator is the bone. The long-term regulator is actually, of course, the intestine. And there are three major hormones. Calcitonin is a hormone which decreases calcium. PTH is the one which increases, and calcitriol also is the one which increases through the intestinal absorption. The most important hormone here is PTH, and PTH increases calcium levels, also decreases phosphorus level. Anybody who has low calcium should have high PTH and therefore low phosphorus. So hypocalcemia should have hypophosphatemia. High phosphorus with a low calcium is a very, very direct indicator of a parathyroid related cause. So the most important investigation when you're looking at anything, look at what is most important. Phosphorus is most important from that regards. Now this calcium is sensed by the calcium sensing receptor. Now when should you suspect hypocalcemia? There are very non-specific manifestations. Anybody with seizures, measure calcium. Unexplained cardiac failure, intracranial calcification, a common referral from neurologists. They have seizures and then they do a CT, they found basal ganglia calcification. This is long-standing hypocalcemia. Raised intracranial pressure, stridor, and long-standing hypocalcemia will also cause cataract. Any preterm below 36 weeks, birth weight below 1500 grams, and conotruncal defect should be evaluated for hypocalcemia because that could be DiGeorge syndrome in that regards. Now, calcium should be done in a fasting state. It can be low in hypoalbuminemia. So best is to do a ionic calcium or you use a corrected calcium in that perspective. In that regards, you can say for every 1 gram decrease in albumin, the calcium goes down by 0.8. So you can actually use this sort of a cutoff to notify that in that regards. Phosphorus should first thing in the morning in a fasting state. Very importantly, do not use a tourniquet or a squeeze sample. Where is phosphorus in the body? In the cells or out of the cells? It is an intracellular ion. So if you squeeze like potassium, phosphorus, magnesium, their levels can really go up. So you should never use a squeeze sample and you need an age-specific level. Often the reports that you see actually are adult levels. So you can't use adult levels. Infancy, the levels can go up to 8. And childhood, they can go up to 6. So these are the cutoffs that you want to use. And adults, the cutoffs are lower. So don't go by the adult cutoff in that regards. Calcium and parathyroid hormone have a log linear relationship. So if your calcium is low, your PTH should be sky high. If your calcium is high, PTH should be 0. So if you have normal PTH with low calcium, this means the PTH is actually low. So you have to interpret in the light of calcium levels. PTH is very thermolabile. If you do not process it immediately, do not send it in ice, the level will always be low. So if you send to a collection center, the person goes and keeps it for hours, your PTH will be 0. You will not have much value. So always do it immediately. So if your calcium is low, PTH should be very, very high. If your PTH, however, is low, and I say less than 70, then you think of hypoparathyroidism in that regards. So hypocalcemia, the common causes are vitamin D related or PTH related. The most important test is phosphorus. High phosphorus with hypocalcemia means a PTH problem, hypo or pseudo hypoparathyroidism, or rarely a renal failure. If your PTH is high, that is a normal response, but if you have a low PTH, it of course is a hypoparathyroidism. Then you can look at the vitamin D level and calcitriol. I would say the most important is phosphorus, PTH, and creatinine, which will give you the right clue in that perspective. We have developed a calcium interpreter in which if you can just enter the values of calcium and sequentially enter the other values, you will get the right diagnosis in that perspective. So a combination of these parameters will give you a clue. An interesting thing is urinary calcium. If your calcium is low, your urinary calcium should be low. Body want to conserve it. But if you are losing, it means that the body's sensing of calcium is defective. So approach is you look at, first of all, hypomagnesemia, hypoalbuminemia, and phosphorus load. If they are not there, look at phosphorus. Low phosphorus, vitamin D related. High phosphorus, PTH related. So the phosphorus is low, get a vitamin D for vitamin D deficiency or resistance. If you have a high phosphorus, look at creatinine to identify a renal failure. And if it's not there, for PTH related causes. That's the thing. So first case, we'll start 4-month-old boy with nephrotic syndrome. Calcium is 7.2. Child is asymptomatic. Dr. Rashmi, do you think this calcium is extremely low?
Hello. So we know that calcium 40% is bound to albumin, and we've not done a ionic calcium. I would like to know either the ionic calcium or the serum albumin levels. So here we go. Serum albumin were 2, so we can use the corrected calcium values. So as measured calcium plus 4 minus albumin into 0.8 milligram per deciliter. So corrected was 8.8, which is almost normal. So this, we will not label this case as a hypocalcemia. This, as albumin becomes normal after treatment, this calcium is going to become all right. But nevertheless, in nephrotic syndrome, we should give calcium supplement because vitamin D takes the calcium out of the bones, and
especially if you're on steroids, you have to give.
And if you
So a very important message by Dr. Rashmi that you correct for albumin level or you go for ionic calcium. Now, ionic calcium is readily available. One caveat is that often when you get the blood gas report of calcium, I am not very happy with those reports. What's your opinion, Dr. Rashmi?
So actually you need different probes for electrodes for measuring different ions. So you have to update and match those probes every time. So sometimes electrolytes are not matched, especially so calcium. Sodium, potassium almost give the accurate values, but not the calcium.
So the blood gas reported ionic calcium, be cautious unless you have a very regular standardization of the machine which is happening on that regard. So ionic calcium is preferred. 4-year-old girl with tetany with an ionic calcium of 3.1. So this is low. Phosphorus is high. PTH is also high. Diagnosed as pseudo-hypoparathyroidism because we say hypocalcemia, high phosphorus, and then you are saying PTH is high. This is pseudo-hypoparathyroidism. Dr. Mahesh, do you agree with the diagnosis?
As you said in the beginning only, that first thing that you need to rule out, whenever there is a high phosphorus, there are 3 possibilities. Either there may be a phosphate load, or there may be a renal related problem, so maybe chronic kidney disease, or there may be a PTH related problem. But the first and the most important thing that you need to remember, always do the creatinine before making a diagnosis of pseudo-hypoparathyroidism. So what is the creatinine level in this child? As we see here, the creatinine is 2.4. And that is comparatively more common and more on a higher side. So the diagnosis is actually in this condition is CKD.
So very important, do not avoid the algorithm. Don't do unnecessary expensive tests. Do a creatinine first. This was very, very high in that
At
regard.
the same time, you should also need to see the clinical presentation.
Yes.
So in clinical presentation, if there is a if there is an acidotic breathing, short stature, anemia, then probably you're dealing more with a chronic kidney disease.
1-year-old boy with seizures, calcium is low, 5.4, phosphorus is high, is reported as 6.1, so not that high. PTH is 11, so PTH is low for the level of calcium. Definitely, there is no response to IV calcium. Dr. Deepak, what do you think? This is hypoparathyroidism?
No, before ruling out all those endocrinological causes, we have to look for the basic causes of seizure, like electrolyte, glucose, magnesium. So we should first rule out all these basic causes. So can I know what is the magnesium level, please?
Yes. So as you said very rightly, if you have refractory hypocalcemia, before you do much, do a magnesium. So magnesium, creatinine, these are basic worker. Magnesium is low.
It's very, very low. So we should know why this magnesium is low in this child, and we have to investigation investigate this further.
So that was given intramuscular magnesium improved very well, but once we stopped intramuscular, his magnesium again went down and hypocalcemia. And then we got a genetic testing done, which showed that there was a problem in the magnesium transporter, which is there in the intestine and in the kidneys. So this child was losing magnesium from the gut and the kidneys. We had to give around 100 times the usual dose of magnesium. She is on magnesium sulfate, which has to be broken injection, and she drinks that at least 20 ml per day, and then her magnesium and calcium is fine. So hypomagnesemia is most common in malnutrition. So if you have refractory hypocalcemia, give magnesium, they will improve, but you can also have some genetic causes in that setting. 3-month-old girl with seizures, ionic calcium is 3.2, phosphorus is low, PTH is also low, diagnosed as hypoparathyroidism. Now, Dr. Vibha, do you agree with this?
Definitely not, sir, as we have hypocalcemia along with the hypophosphatemia. So when we have hypophosphatemia, the PTH level should be high. So in this case, the PTH level is low. So we should think about what is the transport is proper or not during the PTH transport, because PTH is a thermolevel. So when it is left without the ice, it will gone. So I think in this case, the cause of low PTH is the improper transport of the PTH, not the cause. It's due to hypoparathyroidism.
So you remember that anybody who has got hypocalcemia and hypophosphatemia, PTH is working. So how will you have low PTH? So this is something which is clear. So you are going more towards a vitamin D cause rather than a PTH cause here. So clearly in this scenario, vitamin D was very low. And as Dr. Vibha pointed out, somebody had sent to a collection center and they kept it there, the level will be low. So the message is PTH should be done in lab which are doing PTH, or directly they will transport in ice. That's a big message. Otherwise, you are wasting your money. So I talked about growth hormone basal being waste of money. PTH not done properly is also the same thing. So transport PTH on ice. If you have low phosphorus, exclude renal failure, exclude a parathyroid problem in that regards. 1-week-old boy with seizures and low calcium. Phosphorus here is very, very high. Creatinine is normal. So now we have taken care of many things. And magnesium is also normal. So I think we have no doubt there. Most things are normal. So Dr. Rashmi, how will you now go ahead with this?
So since calcium, this child is having low calcium, but phosphorus is high. So we will go to the algorithm of high phosphorus. So this high creatinine was, phosphorus is high, but creatinine is normal. So we can think of these two things, either pseudo-hypoparathyroidism or a hypoparathyroidism. So we do a PTH. So PTH levels were very low. So this case should be of hypoparathyroidism. And clearly, as the history says, there was seizure, and this is a DiGeorge syndrome. This child we saw, or both of us saw about a year ago.
So very early onset hypocalcemia, always think of some cause. Why does this child has hypoparathyroidism? And one of the common syndromic causes is DiGeorge syndrome. There you have cardiac defect, abnormal facies, cleft lip. This child had a very low level of TLD, and that was a clear-cut clue which was there. And these conditions are extremely difficult to manage, and they will have a lot of issues, but at least you should identify them at the right time and do a genetic study, and there will also be a cardiac defect.
So this child had come with repeated admissions for seizures at some other hospitals. He came, and every time he was diagnosed as hypocalcemia, but every time hypocalcemia was treated symptomatically, but the root cause was not treated.
So identifying the cause is very important, and you can easily have done it because his phosphorus was very high. So high phosphorus is equal to PTH problem, cardiac evaluation essential in hypoparathyroidism. 10-year-old boy with seizures, ionic calcium is 3.1, and this went to a neurologist. They got a CT scan done, and what they found here is that some funny calcium deposition is there. So do you think this requires the endocrine evaluation, Dr. Mahesh?
So in this child, when definitely seizures are explainable on the basis of hypocalcemia. So you need to try to find out the cause of hypocalcemia. And all of us know that hypocalcemia due to hypoparathyroidism or pseudohypoparathyroidism, both those can cause the calcification in the brain. But there is an associated clinical features that you also need to see. So if a child is having a depressed nasal breath, if there is a metacarpia, those are the few indications that probably suggest that this child may be having a pseudo-hypoparathyroidism. So accordingly, you can investigate further. So on investigation, if creatinine is normal, just like I said in the previous case, if creatinine is normal, then you need to go for the parathormone level. And if parathormone is low, just like in the previous, Dr. Rashmi talked about that particular case, this is hypoparathyroidism. If pH is on a higher side, just like in this particular case, the PTH is more than 200, so that is significantly very high. So most probably this is a child with pseudo-hypoparathyroidism.
So this child actually had cataract, he had brachymetacarpia, he had cutaneous calcification, high PTH. So this was clearly a case of pseudo-hypoparathyroidism. So we discussed a lot about hypocalcemia. We'll move towards rickets, which is a very common presentation. And we know that rickets means cup and frame, which is observed in this regards. And these radiological picture is important. Now, if you have rickets, step would be to give a course of vitamin D. The IAP has come up with guidelines which have shown that you should give a course of vitamin D, which is daily for 12 weeks or alternate day intermediate regimen. Also, they have mentioned about equivalent to that or 60,000 international unit fortnightly. So the first step is when you have rickets, do not rush to do investigations. Give them a course of vitamin D. And if they are not responding, then only you start worry. You expect that with treatment, calcium may come down, bone pain may happen, alkaline phosphatase may actually increase, and the child may complain of increased bone pain. This does not mean that this child is not responding. This means actually the child may be responding. So if you are not giving calcium, they will develop hypocalcemia. The only thing which is important is line of healing. So refractory rickets is one in which you have adequate treatment and lack of response. Other features like polyuria, seizures, fractures and growth failure, you start thinking of refractory rickets right at the diagnosis. However, you may have skeletal dysphasia which looks like rickets. You may have not given enough calcium, vitamin D and then labeled as refractory rickets, or high ALP and bone pain was considered a marker of lack of response, which is not the case in that scenario. So if you have rickets, it could be because of deficiency, you give therapeutic response. If it's refractory, it could be because of a calcium problem where you have early onset, high PTH and low calcium. While if it could also be because of acidosis with urea failure to thrive and phosphopenic forms, which has late onset with lower limb involvement. So clinical parameters will give you a clue. The question is it rickets? Is it refractory? And what's the cause? So if you have the initial workup, the most important test here again is phosphorus. What do you expect the phosphorus in a child with rickets? High or low? So phosphorus is the most important agent causing bone apoptosis and cause a problem of phosphorus deficiency, you will have rickets. So if your phosphorus is high, this is renal failure or PHP. Otherwise, this is all because of a problem of nutritional deficiency. If urinary calcium is high, consider distal RTA. If PTH is normal, this is hypophosphatemic rickets. If alkaline phosphatase is normal, normally alkaline phosphatase should be very high. If it's normal, this is RTA or chronic kidney disease, and acidosis means RTA. So if you want to classify, the most important test is phosphorus. If your phosphorus is high, think of renal failure or PHP. If your calcium is low, think of vitamin D deficiency or renal failure. If your PTH is normal, this is hypophosphatemic rickets. And urinary calcium, if it is high, suggests RTA. So some basic workup, phosphorus, creatinine, urinary calcium will give you a diagnostic clue. And then, of course, blood gas will give you a clue. So the approach is, if your phosphorus is high, creatinine is high, this is CKD. If your phosphorus is low, go for renal tubular acidosis, hypophosphatemic rickets, and then finally you can go in terms of vitamin D dependent rickets. So phosphorus becomes very, very important. So next case, 3-year-old boy with rickets given 3 doses of vitamin D Now, with bone pain, high alkaline phosphatase with a normal calcium labeled as refractory rickets. Dr. Deepak, do you think this is refractory rickets?
No, sir. Actually, in the practice, it's happened that parents thinks anything which say on treatment is refractory to the treatment. And even the unexperienced doctor in the initial stages, they do think like this. But as you have already said that during treatment for the kids, bone pain and alkaline phosphatase may actually increase. That is actually good response to treatment. So for the response, that is not the actual thing to look for. We have to look for the line of the area. And we can clearly see there is beautiful line of healing on the X-ray. So this is not actually refractive, but rather sensitive, I can say, case.
So don't go for biochemical parameters, go for an X-ray. If X-ray show the line of healing, forget about it. If you diagnose refractory rickets, you have to do multiple investigations, which are not really required in most cases. So key messages are bone pain and ALP may increase with vitamin D, and line of healing is the best marker. We have a 4-year-old girl with rickets treated with the osteocal 5 ml twice a day with no improvement. And now they come to you with the X-ray showing no line of healing and refractory rickets. Dr. Vibha, what do you think is happening here? Is it refractory rickets?
No, sir, because before making a diagnosis of refractory ricket, we should be ensured that the treatment has been given for the adequate period of time, that is 12 weeks. But in this case, the treatment has been given for 30 days, and this 5 ml BD calcium is also not the optimum dose required for the vitamin deficiency.
So do you recommend the vitamin D separately or as part of, because many preparations have vitamin D in them?
No, sir, separately. That is the IAP guidelines recommended a dose of 60,000 fortnightly for 5 doses and then monthly. And the daily dose of the calcium should be 50 to 75 milligram per kg per day.
So you should always give calcium along with vitamin D and then assess. So parental vitamin D should be given to whom?
Patients who have malabsorption like celiac disease.
Okay, so don't give IM calcitriol. Often we see orthopedician giving arachital weekly, and the child comes to us with hypercalcemia. Vitamin D is a safe drug, but if you don't use it properly, it will cause hypercalcemia, polyuria, constipation, and that becomes a big problem. So this is inadequate treatment, not an abnormality. 5-year-old girl with rickets, polyuria, weight is 10 kg, short girl. She has metabolic acidosis labeled as distal RTA. Now, Dr. Rashmi, do you agree with the diagnosis of distal RTA in this case?
See, immediately you cannot diagnose as distal RTA. You have to have some basic parameters like phosphorus, etc. So what was the phosphorus in this case? Phosphorus was clearly high, 9.9 milligrams. So I would like to know the value of creatinine. So clearly this is a case of renal disease, which is causing rickets in this child because of high phosphorus, high creatinine, low calcium. So this is the rickets because of the renal disease.
So this was clearly a glomerular disease rather than a tubular disease. So before you go ahead with rare disorders, do simple tests. I think that is the key message we are giving. High phosphorus suggests that. 12-year-old girl with multiple fractures, failure to thrive, polyuria and myopathy. You can see severe bony deformities, losers show multiple fractures. Dr. Mahesh, could this be vitamin D deficiency?
Yes, whenever there is child comes with us with a multiple fracture, we always think about there is a first cause, maybe a vitamin D deficiency associated with malabsorption, or maybe the primary vitamin D deficiency. But usually, most of the time, the nutritional vitamin D deficiency not presented with fractures. There may be bony deformities that can be the presenting features, but the fractures are not commonly the clinical features. Fractures, maybe you can consider the other differential diagnosis. There may be primary metabolic disorders, bony metabolic disorders, or secondary bony metabolic disorder. So we will definitely go on our protocol. So we will see the phosphorus that is 2.1. So that is on a lower side, and creatinine is 0.6. So if we will see that particular thing, and the next thing we will require is the blood gas. So on the blood gas, there is a 7.12 pH. So that is definitely showing most probably this child is having a metabolic acidosis. Though obviously we need more parameters to say hyperchloremic metabolic acidosis. And at the same time, if you do the electrolytes will be on a lower side, and potassium is on the lower side. We can think about this is a renal acidosis. And you can confirm by doing the urinary calcium.
So she had calciuria and nephrocalcinosis, suggestive of distal RTA. So fracture in a child who really comes to you with rickets means a pathological cause. It is usually not a nutritional cause. You have to think RTA in that regards. 14-year-old boy with refractory rickets, Dr. Deepak, you can see this case. There is a lower limb involvement, which is there predominantly. There are a lot of bony issues which are happening there, bone resorption. What do you think is happening here?
Sir, as you can see, this having rickets and predominantly lower limb involvement, that too in a 14-year child. So clearly indicates this is probably not nutritional, and we have to think beyond nutritional rickets. And in a male child, most probably looks like hypophosphatemic rickets. So can we have biochemical parameters?
Yeah, so biochemical history show the phosphorus level, which is low. There is no metabolic acidosis here. So we are now going into the algorithm towards this area. And
So-
calcium and for PTH is also normal.
So in this side, we can clearly see the phosphate is normal, calcium is normal, and parathyroid level is probably normal. So this is most likely hypophosphatic rickets, and we have to treat with phosphates. And recently we have monoclonal antibody too.
So if you have a late onset lower limb abnormality, that is hypophosphatemic rickets. And here calcium and PTH level will give you a clue. We'll touch base briefly about hypercalcemia, which is rare but important to identify. If you have a sick neonate with dehydration, polyuria, hypotonia, encephalopathy, get a calcium done. So when you electrolyte, also get a level of calcium done. Hypercalcemia, which may be there. So you need to be careful in terms of evaluation in that regards. So calcemia, as I said, with multiple abnormalities. And if you think of hypercalcemia, the most common in children, I would say you will see is vitamin D excess. The most common cause is somebody has prescribed vitamin D. The parents are giving for multiple time. They will come to you with polyuria, constipation, irritability, dehydration. If you don't measure the calcium, you will miss it. I have seen cases who became very sick, requiring ICU admission for hydration, diets, and steroids. So always, if you have a child with irritability, failure, ask whether they are giving too much vitamin D and get a calcium done in that regard. Hyperparathyroidism is rare, but this is a very important thing in that regard. Again, PTH-related causes, your phosphorus will be low. Vitamin D-related causes, your phosphorus will be high in that regards. And PTH will give you a clue in that regards. So PTH should be interpreted in the light of calcium. Anybody with a high calcium should have a low PTH. If you have a detectable PTH with a high calcium, this suggests that there is a hyperparathyroidism in that regards. So if PTH is below 20, this is vitamin D related, vitamin D excess, or some other disorders which are there. If you have PTH which is high, then you have to think of hyperparathyroidism and an endocrine referral is required. So a 12-day-old girl with irritability, dehydration, calcium of 18. So the first good thing is that the calcium was done. Otherwise, often calcium is not assessed in this setting. Dr. Vibha, what do you think in this case?
So definitely the child has hypercalcemia along with the symptoms of hypercalcemia like dehydration and the irritability. So if we go according to the algorithm, after the calcium level, we need to go for the PTH level, whether it is high or low. So in this case, PTH level is 120, which is quite high. Then after the PTH level, we should go for the urinary calcium creatinine ratio, whether it is high or low. And in this case, the urinary calcium creatinine ratio is low, which is 0.3. So this is going towards the calcium sensing receptor defect. And if the patient present at this very young age, so it is a neonatal severe hypoparathyroidism in this case.
So if you have a neonate with very high calcium levels, it is most likely a life-threatening condition, requires immediate stabilization, and would require a parathyroid surgery. Otherwise, the child will not. We had a very good case presented yesterday. So clearly, polyuria and dehydration, think of calcemia. 2-year-old girl with abdominal pain, ultrasound showed nephrocalcinosis. This was unusual. But then when we did a calcium, it was 13.6. Phosphorus was high. So high phosphorus, as I said, excludes a PTH cause. Now, Dr. Rashmi, what do you think could have gone wrong in this child?
So we will again go to the algorithm. So here PTH was, what did you say? PTH was
Undetectable. Yeah.
undetectable. So since we know high calcium, PTH is undetectable, and there is low 25 hydroxy vitamin D. So
vitamin D was very
vitamin-
high
yeah.
actually. So when we did vitamin D, it was 200. Below.
So yeah, 20. So it was very high. So this clearly means that people must given extra doses of vitamin D, and that's the reason for excess of vitamin
So
D.
this is clearly an exogenous steroid use. Remember that PTH has a conservatory effect in calcium excretion. So if you have same level of calcium because of hyperparathyroidism, urinary calcium will not be that high. But if it is because of vitamin D, your urinary calcium will be very high. Develop nephrocalcinosis immediately. So this is vitamin D toxicity. What will you suggest in this case, Dr. Rashmi?
So in this case, we will suggest, of course, if this is vitamin D toxicity and what are the symptoms of the child, because this child may have severe headache and this child may land up in coma also.
Yes.
So we would like to admit the child, and steroids are the mainstay of treatment, and good hydration should be given. So many a time children need PICU admission.
So anybody whose calcium is above 13 should ideally be admitted. Give a good amount of fluid, give diuretics, and start steroids. Steroids will be required for 2 to 6 weeks. Ask them to avoid milk and other dairy products during that time. Closely monitor their calcium. So this could be a life-threatening disorder actually. And we have seen many cases because of vitamin D toxicity in that scenario. 15-day-old girl with preterm, 28-week gestation with hypercalcemia. Phosphorus is on the lower side. PTH is undetectable. Dr. Mahesh, what is going wrong here?
So this side is actually a 15-day-old girl admitted at 28 weeks, so most probably admitted in NICU. Her phosphate is definitely on a very lower side, and PTH is less than 1. So as you said already, that it doesn't look like to be a PTH related cause. So PTH related cause probably is out in that scenario. So when we go with this algorithm, we will find out this may be a vitamin D related cause. So vitamin D 25 OSD is on a lower side, and calcitriol is on a higher side. So you can say, and phosphorus is on a lower side. So whenever there is a low phosphorus, it usually increase the 25 hydroxylase. So that will result in more production of calcitriol, and that will result in ultimately the hypercalcemia. So it looks like to be more often TPN related, where probably the low phosphorus was given in the setting, and that resulted in hypercalcemia.
So in TPN, if you give too much phosphorus, you will have hypocalcemia. Too little phosphorus will cause hypercalcemia. So this is very, very important to give the right dose of phosphorus. 4-day-old boy with seizures, birth weight 3.2 kgs, asphyxia. Calcium is 18, extremely high. Phosphorus is 4.2, PTH is 0. Dr. Deepak, what are we looking at?
So as we can analyze from this case history, this hypercalcemia doesn't look like to be parathyroid related. There is something more. And in this case, like asphyxia, we have to look for particularly subcutaneous nodule if there is something like fat necrosis or like that. So can we examine this child? So you can clearly see there is some palpable nodule. So this is fat necrosis case probably. And we can see the calcitriol is way beyond the normal limit. So probably our diagnosis is correct. This child is having automatic conversion from the 25 hydroxy vitamin D to calcitriol, and this can clearly lead to severe hypercalcemia, life-threatening. So it's good that the pediatrician has done all this wonderful workup. So the treatment will require good hydration, diuretics, and steroid for a few weeks.
So one clue, if you have hypercalcemic child, feel for the skin. If there are very firm violet colored nodules and a history of birth asphyxia, this may be the first sign that this is actually a fat necrosis. And we had a very good case with Dr. Arpita presented yesterday. And in that scenario, this fat necrosis area, you have got a lot of granulomatous tissue coming up, and that's converting a lot of 1-alpha hydroxylase, converting it into calcitriol, causing hypercalcemia. Again, a course of steroid is required in that regards. So at this point of time, we are able to finish off the calcium module at a very reasonably brisk stage. I think it was hopefully clear. So if there are any questions from the audience, we will like to have them.